Hello, everyone, and thank you for having me here. It's always an honor and a privilege to speak to a group like this. So, as Kevin mentioned, my name is Armando Nahum. I am a patient safety advocate, first and foremost. I live in Atlanta, Georgia, and today I'll be talking about my journey. You know, someone once said that in life, even more than education, experience is sometimes the best teacher. Well, if that is true, I can tell you with all certainty that there's no one I know of in America today who has been taught more or has been more profoundly affected by the personal devastation and particular loss caused by hospital-acquired infections than my own family. So I would like to illustrate a timeline of my family's experience with our infections. The first case was my dad, Quint Nahum. See him on the left. Dad caught a bacterial pneumonia in the hospital in Rochester, New York, after having suffered a mild heart attack. And a couple of weeks before Thanksgiving of 2005, Dad was 79. And after he acquired a bacterial pneumonia, his doctor decided, which I learned many years later, that was pretty cool, not to bring him back in the hospital, but to give him a course of antibiotics and let him stay at home and let the antibiotics work. And Dad recovered completely, so that was great. And then the second case was my wife, Victoria. So in the year 2000, she had a surgical procedure that turned into a nightmare that took 6 years to discover. And a few months after the surgery, a mysterious laundry list of bizarre symptoms began to adversely affect her health. As time passed, she experienced debilitating fatigue, burning pains in most of her joints, chronic muscle pain throughout her entire body, many fevers, unexplained rashes, numbness in her arms and legs, dry eyes, and actually her tongue would be stuck to the roof of her mouth when she awoke every morning. Really bad stuff. And over the months that turned into years, she visited GPs, neurologists, dermatologists, ophthalmologists, rheumatologists. You pick any allergist. Chances were we written them a check. And it took 6 years to finally get the right diagnosis. So basically, my wife was not prepped correctly for her surgery, and therefore contaminated with her own flora that turned into staph epidermidis that percolated inside her body, sapping her strength, making her sick, and robbing her of her good health and active years she could never get back. The third case is our son Josh. On September 2nd of the same year, 2006, our son was on his last jump. He landed too hard, his final jump, breaking his femur and fracturing his skull. And after almost 6 weeks in ICU, and after battling not one but 2 cases of MRSA, ICU psychosis, or delirium, as they call it, Josh seemed to be on a better road to recovery, and it was doing so well, he was admitted to a nearby physical rehab facility. But suddenly, in the midst of rehab, Josh began feeling nauseous and running a 103-degree temperature. For these reasons, he was transported back to the ICU to determine why. Later that night, Josh suddenly coded and stopped breathing, becoming comatose with no respiratory effort whatsoever. Josh was attached to a ventilator to save his life. And Josh's neurosurgeon was called from home, and upon arriving, he performed a lumbar puncture to determine why the brain was swelling again. Enterobacter aerogenes, a virulent gram-negative bacteria, was found to be present in Josh's cerebrospinal fluid. So at that point, he performed another ventriculostomy, at which point Josh awoke and was responsive again. And so the ventric procedure saved Josh's life, but the ensuing spinal cord injury had tragically and permanently interrupted his ability to breathe on his own ever again. Josh had experienced a brain herniation with irreversible spinal cord damage down to the thoracic, making him a permanent ventilator-dependent quadriplegic. Josh died 2 weeks later, but not from his original injuries. Josh died unnecessarily from hospital-acquired bacteria that caused so much pressure to be put on his brain that it was actually forced into his spinal column, ending his short but unforgettable life. And then ultimately what killed our son was sepsis. You know, they call them hospital infections, nosocomial infections, healthcare acquired infections. Truthfully, you can call them whatever you want to. They're very bad news for everybody. Because I'm sure nobody wants to see another father like me crying with my head in my hands. And no hospital wants to explain to parents why their child is dead from their care. I certainly don't know of any nurse who wants to see another patient they've cared for and gotten to know die. No doctor that I know wants to feel like he or she have failed in the treatment of a patient. And certainly no administrator wants to fear that a lawsuit is on the way. But you know what? More importantly, no family wants to have to say goodbye to the one they love so much. And so throughout my initial research, the papers, the abstracts, the stories of the dead and dying, sometimes it felt to me like we were losing people right and left, like we didn't know how to stop it. And I remember asking the infection preventionist at the hospital that Josh was at, how did he get this infection? And he looked at the ground in quiet voice. He said he didn't know. And it was such an impotent thing to say to a parent of a dying child, because I remember being dumbfounded to hear that answer fall out of his mouth. He was clearly embarrassed to say it, and inside I felt angry and that he didn't know. And then suddenly the other side of my brain kicked in, and I remember thinking, Armando, how can you expect one person to know every single germ in this hospital? And my heart went out to him. I asked him what was there to do. What could we do now? And with a dreadful silence, he just shook his head. We have the ability to grow sheep from a single cell. Surely we can figure out a way to save our son from dying. And yet, they couldn't do it. For all the opportunity we have in this country, for all the technology and education and advantage, our son died anyway. And after our son died, we reached out to the CDC, and under their recommendation, we established the Safe Care Campaign, which is an organization dedicated to infection prevention. And over the last 13 years, we have worked with hospitals really across the globe. So this press release came out in January of 2019, and the new data released by the Agency for Healthcare Research and Quality and the Center for Medicare and Medicaid Services that showed reductions in hospital-acquired conditions such as adverse drug events and healthcare-associated infections, and helped prevent 20,500 hospital deaths and save $7.7 billion in healthcare costs. This is from 2014 to 2017. So HRQ preliminary analysis estimates that hospital-acquired conditions were reduced by 910,000 in the 3 years from 2014 to 2017. And the estimated rate of hospital-acquired condition dropped 13%, so from 99 per 1,000 acute care discharges to 86 per 1,000 during the same time frame. But you know, every time I see these numbers like these, I ask myself the same question. So now what? We should be doing so much better than this. This is just not acceptable. And what I believe is really a total system approach. And this is what I mean. Advancing patient safety requires an overarching shift from reactive, piecemeal interventions to a total system approach. I believe we need to embrace wider approach beyond specific, circumscribed initiatives to generate change. So here are some fundamental findings. Initiatives can advance only with a key focus on teamwork, culture, and patient engagement. And here are the 8 recommendations. You have to ensure that leaders establish and sustain a safety culture. Improving safety requires an organizational culture that enables and prioritizes safety. The importance of culture change needs to be brought to the forefront rather than taking a backseat to other safety activities. Number 2, create a centralized and coordinated oversight of patient safety. Optimization of patient safety efforts requires the involvement, the coordination, and oversight of national governing bodies and other safety organizations. The third one is create a common set of safety metrics that reflect meaningful outcomes. Measurement is foundational to advancing improvement. And to advance safety, we need to establish standard metrics across the care continuum and create ways to identify and measure risks and hazards proactively. And number 4 is increase funding for research in patient safety and implementation science. And to make substantial advances in patient safety, both safety science and implementation science should be advanced to more completely understand safety hazards and the best way to prevent them. And we'll move to number 5, which is address safety across the continuum of care. Patients deserve safe care in and across every single setting. Healthcare organizations need better tools, better processes, and structures to deliver care safely and to evaluate the safety of care in the various settings. In the U.S., I'm afraid we failed terribly on handoffs. Number 6, support the healthcare workforce. God knows they need all the help we can give them. Workforce safety, morale, and wellness are absolutely necessary to provide safer care. Nurse, physicians, medical assistants, pharmacists, technicians, and really, truthfully, everyone that is involved in the care of our patients need the support to fulfill their highest potentials as healers. Number 7 is partner with patients and families for the safest care. Patients and families need to be actively engaged at all levels of healthcare. And at its core, patient engagement is about the free flow of information to and from the patient. And finally, number 8 is to ensure that technology is safe and optimized to improve patient safety. Because optimizing the safety benefits and minimizes the unintended consequences of health IT. Absolutely critical. So let's talk a little bit about number 7, partnering with patients and families to create safer care. I'm sure most of you are familiar with the Partnership for Patient under CMS, or the Patient and Family Engagement 5 metrics. And they're really broken down in 3 buckets. At the point of care, it asks, do you have a planning document checklist with patients who have a scheduled admission? And then do you have, or do you conduct shift change huddles at the bedside or bedside rounding? At the organizational policy and protocol level, it asks, do you have dedicated patient engagement staff? And do you have a patient and family engagement council or a PFAC? And then finally, at the organizational governance, do you have patients and families serving on governing boards or board committees? And you know, over the years since the Partnership for Patients was formed, we never really paid too much attention to number 3, having a dedicated patient engagement on staff. And this is really crucial because last year I was fortunate to participate on a wonderful study across the country. And there was a study that I participated on, a CMS funded with Vizient, which is one of the HINs, or Hospital Improvement Innovation Network. And the study had a single objective: to determine if a correlation exists between patient and family engagement implementation and improved outcomes. And the research questions that were broken down basically really into 3 questions. Do hospitals perform better in quality and safety when they have patient and family engagement implemented with their organization? Do hospitals perform better in quality and safety when patient and family engagement is integrated into quality improvement programming? And then, what impact does the voice of the patient have over an organizational quality and safety performance? So the study was totally blinded. It was conducted over 11 hospitals, 2 were test pilots, and we had 2 teams, a research study team and an on-site team, or boots on the ground. And here's what we came up with. We asked the help of an engineer by the name John Scallon, who has done a lot of work for CMS, and he helped us tremendously to achieve this graphic from all our finding. We call this the logic model. As you see it on the top left, there's a circle that says hospital commitment and strategy. Well, we know that every hospital has a commitment and a strategy on this. And if you follow the arrow to the right, they all have managed with quality and safety programs. They have a budget, they use metrics, accountability, and structure. But here's the best thing. When you add the patient and family engagement portion to it, and you actually integrate it into quality and safety, and you embed it into the culture of their organization, look what happens to the actual bars on the right. These are hospitals, and you see it in their purple bars. And the first one on the left is the quality and safety system alone. But the one on the right is having integrated quality and safety in their culture. And it works absolutely unbelievable. So here's what we actually learned from the study. We learned three major buckets, if you will, three major items: leadership, quality and safety, and innovation. And under leadership, leaders align patient and family engagement with organizational vision, mission, values, and they drive organizational behavior through explicit internal and external messages. Basically what that means, leadership eats, sleeps, walk, talk, PFE, constantly. They're all over the place. Quality and safety is the organization provides training and education to patient and family advisors to optimize their contributions because they believe that without them they couldn't do it right. Committee, department, and unit leaders partner with patients and family advisors to gain a better understanding of specific issues, processes, and procedures, and acronyms. God knows they use a lot of them. And do patients and families currently serve on committees and work groups involved in facility design? Are they part of the system? Are they treated like staff? Organizations also train staff to expand their partnership capabilities with patient and family advisors. And improvement and outcomes over time are always measured and tracked, including notations of patient and family advisors' contribution. And then the last one is innovation. We saw some hospitals that, my goodness, organization, they liberate their patient and family advisors from conference room and deploy them across the organization on various committees. This is what MedStar does. You heard Kevin mention that that I participate in their MedStar Institute for Quality and Safety. I'm one of their directors for patient and family engagement. And that's exactly what they do. That's the part, the innovation part. And then the PFE program continuously evolve to meet the needs of the organizations. And then this is really what we provided CMS. This is what we call the change package. And it's a PFE integrated quality and safety package. And I know it's a little bit difficult to read, but it was approved by CMS. And it has the basic three drivers that I talked about: leadership, the quality and safety portion, and then the innovations. And then it has all the sub-drivers attached to it. So here are the key takeaways. The major finding and strength of the study is the above average statistical correlation demonstrating between patient and family engagement and clinical outcomes. And primarily, this came through in readmissions and falls. And few studies really have developed scientific evidence that support the influence of PFE activities on outcome measures. But we've seen organizations that, as I mentioned, the two primarily ones were readmissions and falls, but we've seen Emory University, for instance, they reduced their patient and family advisors committee reduced infections to 25%. They even won an award. And that's a lot of numbers. That's pretty major. So I'm sure I'm taking too much time here. I'm going to stop here and see if there are any questions.